Hello, everyone, and thank you so much for joining our webinar today with Dr. Peter Weiden. Dr. Weiden is a professor of psychiatry and director of the Psychotic Disorders Program at the Center for Cognitive Medicine at University of Illinois Medical Center in Chicago, Illinois. After 30 years of research on medication adherence, Dr. Weiden will discuss why he feels the current definitions of medication compliance or adherence have done more harm than good, why many patients may be exposed to major safety problems or accept less than optimal outcomes due to missing information. We are very pleased to have you with us today, Dr. Weiden. Welcome.
Thank you very much, Debbie. I'd also like to thank Mrs. Muffy Walker for inviting me to this. We spoke about 6 months ago, and I hope this will be fun and interesting for you because this journey I have taken about this issue has, I think, a lot of implications in how we all handle our health care, be it bipolar disorder or cancer or anything, in terms of, I think, some of the aspects coming up in the field. So I'd like to share that with you in this talk. And I'm not going to try to necessarily directly help anyone take medicine better, although that's often a question I'm asked. But my goal here is to help you understand certain things in a way that might help you negotiate with family or a physician, or understand where a physician is coming from that might be helpful to you. And first of all, adherence or compliance is not an outcome. I mean, we never think, oh, someone had cancer, did they comply with the cancer chemotherapy? You know, if someone has cancer, we think of an outcome as how long did they live, were they in pain, did they have a quality of life? And the same goes for mental disorders, psychiatric conditions such as bipolar. It's not whether you took lithium or meds that matters in the long run. It's whether you have a life that is stable, that is symptom-free, and that you can go live your life. And however, adherence is a strong predictor, often, not always, of many of these outcomes. So it is something to consider if it can mess up outcome. This basic link is sometimes missed by doctors, because if you're a patient, why should you care about adherence? You should care about outcome. That's also never the only predictor of outcome. I mean, that there are other issues in psychiatric disorders. The meds don't work. There are other complications of substance use and so on. And adherence is a major challenge across all disease areas. So just one quick data slide taken from cardiologists, that if you look at 1,000 individuals who've had heart problems, if you ask them, are you take your medicine regularly, that is a predictor of having a 4 times as high risk of stroke or death after 4 years. Now, you know, there are going to be many people who will take their medicine and still have a heart attack, and many people who won't take their medicine and won't have a heart attack, but it is an issue of risk in these situations. So what I'm going to do today is tell you about the 30 years of my research on adherence, and I would say if this were an easy problem, either for the nation in terms of healthcare outcomes, or for people struggling with bipolar disorder, we would have solved this problem by now. And there are some people in this world who will take their medicine as prescribed and never have an issue with that, and those are interesting people. They are in the minority. So I'm assuming that for many of us, and I'll include myself, and that there have been adherence challenges, and it's not that simple. My perspective really evolved over time. 30 years ago, my mentor, Alan Francis, who is actually in San Diego, told me when I wanted to get a grant on side effects for schizophrenia, he said, you know, you're not going to get funded in side effects. No payers are interested in side effects. They're interested in compliance, because then you can make the case that people don't do well. And I think that there was a lot in that statement that I think talks about how doctors view compliance as a problem for outcome, not in terms of necessarily understanding what the patient's going through. My hypothesis is that the current understanding of medication adherence is very flawed, and as the title says, may do more harm than good. Again, today I'm not going to give necessarily specific suggestions, but hopefully you will get some ideas and it will be interesting. Now, there's been some change in the definition over the last 30 years, 40 years. We used to use the word compliance, which you can see is defined as the extent to which a person's behavior with treatment coincides with medication advice. Now, in 30 or 40 years, we've changed that to adherence, and the WHO, World Health Organization definition is down there, and this is fairly representative. The major change in this is adherence does not sound as much of a power issue or a force issue, and that is an improvement. And the big change is that the patient following the advice has to be mutually agreed upon. So that's it. 30, 40 years, we've changed it to a mutually agreed upon following the recommendation. So I'm going to take shots at these definitions, and let's just talk about some case examples. This is one that I talked to physicians. I'm here, by the way, in San Diego at the U.S. Psychiatric Congress, which is a big meeting for physicians. I'm going to meet Debbie later at this Congress, and this talk has been adapted. But so you have someone with schizophrenia who takes medicines regularly, and Hurricane Sandy, her name, in New York caused flooding in the pharmacy, and the clinic closes, and she doesn't figure out to call the pharmacy, and her meds run out. And then I will ask you or doctors, is Sandy adherent according to the WHO definition? Does she follow her doctor's recommendations? And the technical answer is no, she doesn't. She stopped her meds, and she could have called the pharmacy. But if I present that to clinicians, they kind of bristle at that, and we usually think of someone who's not adherent or doesn't take their medicine, someone that makes a decision to stop. So if someone's in a hurricane or a flood and doesn't take their medicine, we don't kind of count that. Now, here's the important point for you as you think about this, either in your life or your loved one's life, is that there are many times, especially in psych conditions, where the symptom that you are treating, mania or depression or psychosis or lethargy, actually makes it harder to take meds as prescribed. And that kind of stopping medication is not intentional, it's unintentional. And the root of that problem is that the meds don't work as well as they should and don't fix the problem. And often clinicians don't quite understand that relationship between efficacy and outcome. That if the meds don't work right, then it's harder to take them for, and I'll get back to that. Here's a second case. Carla has bipolar disorder, and she sees a psychopharmacologist. And but she's not so thrilled about the recommendation for lithium, so she gets a second opinion, and she finds a spiritual healer whose prescription is daily prayer and daily enemas to get rid of the toxins causing bipolar disorder. Carla follows those recommendations carefully. So no lithium, but lots of daily enemas. Is Carla adherent according to how doctors view adherence? And the answer here is, even though I would not think this is a helpful treatment, is Carla is adherent. She is following a clinician's recommendation. Now, we may have some concerns about that, but that's what she's doing. And here's the major point, is that doctors and patients alike view adherence or compliance as following recommendations. And there's nothing in the definition that requires the treatment to be effective. So when the patient and doctor talk, it's not the effectiveness of what's going on that is, in the forefront. It's whether you're agreeing with the doctor. That is a major problem, in my opinion. That really makes no sense to me, that we would call Carla adherent and Sandy not adherent. That's messed up, and I'm going to show about how that can lead to certain problems, and we'll take it from there. So one is that we're only talking, adherence only matters when the treatment works. Here's the Pill of the Month Club, New Yorker cartoon. Maybe if you're taking meds and they're not working, that isn't the best idea. So, and so the problem is that the conversation and the discussion is usually around, is the patient doing what the doctor has recommended, rather than, is the recommended treatment effective, and if it's not effective, in what way is it not effective, and how can we improve that? And if we have differences of opinion, let's figure that out. So who cares about this? First of all, thank you for listening. I think you do care. But what's in words? What does this matter, how a doctor is trained? Well, if adherence is obeying the doctor's recommendation, that means that you don't want to tell the doctor about when you don't obey. Doctors are authority figures. They are there to help you. And there is a huge problem because of the adherence and that's not a good thing to stop your meds, and you don't want to be a bad patient, that doctors do not have information about what people are actually taking. Notice that's different than if you stop your meds, bad things will happen. It's if you stop your meds, the doctor doesn't get it in terms of what the problems are, and then will prescribe wrong medication or a different medicine or raise the dose. I call this sometimes an arms race between the patient and the doctor. The patient, doesn't do well despite some medicine. The doctor doesn't know that the medicines aren't being taken as prescribed. Doctor raises the dose, then the patient stops that. Doctor adds a med, the patient stops that. And then what happens is, then if the individual is hospitalized, they go to a hospital and the meds are continued in the hospital, and the patient goes into a coma. There are real safety issues involved. So that's one big way that is sort of not talked about, is the information problem. And most people with severe psychiatric problems or bipolar disorder or schizophrenia, these are these are problems that don't go away. So that the accumulated information of whether a med works or not, or what someone is like on X, Y, or Z, is enormously important. And if that information is messed up, that can lead to misinformation, incorrect treatment plans, not just now, but for many years. The other way it messes things up is that if you do not feel safe, and I know I don't, discussing adherence issues because it is a obedience issue, then you're not going to give that information. You're going to be nervous about that. And if the clinician takes this problem personally, I've had many doctors say, oh, my patients take their medicines because they trust me and I trust them. Well, it's not a matter of trust, but if that clinician believes that to be a matter of trust, they will behave in a way where the patient will not want to disclose that. So that's how I think adherence, in addition to what we often see, someone stops meds and doesn't do well, messes things up in psychiatric treatment. This is not sexy in the sense of fancy brain scans or fancy mechanisms of action. This is sort of nitty-gritty but important. And so I would say that we have to be very cautious, but I would make the claim that for bipolar disorder, the meds do more help than not, although they are not always effective. But we can justify talking about adherence because in the long run, or for most individuals, the meds do more help than harm. Here's one example of the way doctors see adherence. Patients stop their medicine, they get sick, they go to the hospital. Well, what if you have a med that doesn't work, so you then get sick, and then as part of your illness you're manic or you're depressed, you stop your medicine and then relapse. The doctor, when you go to the hospital, will say, that person stopped their medicine, and will miss the issue of, hey, well, let's look at why did that medicine not work well enough that it caused that symptom exacerbation. So these are some of the issues. One specific recommendation about the don't ask, don't tell is one thing that is often missed is if the patient does not tell the doctor that they're going to stop medicine, then they're going to have to figure out how to go off medicine on their own. And it is not a good idea to stop medicines quickly, and it's not a good idea to stop medicines without supervision. This is a study of lithium discontinuation, where if you cold turkey lithium, there seems to be a rebound rather than a gradual discontinuation. So again, that's the safety issue. With websites and programs like this, or with the Icarus project, and a lot more written by individuals about these issues, about don't cold turkey things, it is better. But if a patient doesn't report to the doctor, they can't get the help that they need getting off medication. So the information's poor, and that compromises safety. So if we threw out this definition that it is about obedience, about following a recommendation, and thought of it as more of an information problem, that the clinician and the patient desperately need information about what is actually being taken or not taken, to then, and they may not agree, but that the information is as valuable as gold in someone's long-term course. I think that may not solve people stopping meds all the time, but it will improve outcomes by getting better information and stopping the war between patients and clinicians. I'm doing a talk for Medscape tomorrow, and the initial title of that talk was The Adherence Battle, the battle between doctors and patients. Well, I got rid of that title. It's not a battle, it's not a war, we're all on the same side. So what does this have to do with you? I would think about, what is the cost of withholding information and helping clinicians, because they don't know how bad that is. Now, I've mentioned this before. It turns out that the relationship between a clinician and a patient is an enormous predictor of outcome, both good and bad. A good relationship predicts good outcome in all diseases, including bipolar, and a troubled relationship predicts a poor outcome. Now, you may say, well, that may have to do with some people get along better with others, both doctors and patients. So it may not be something that is specific to a doctor or a patient. But the point is that if you can have a good relationship with your clinician or vice versa, that does make a difference. It's not just about medication. And right now, often the adherence discussion is not a pleasant one, either between the clinician, why did this patient mess up my treatment plan, or the patient does not want to be seen as a bad patient. So I do audience surveys on this, and that lots of doctors don't tell their doctors that they've stopped their meds, and usually that's about not wanting to be considered a bad patient or be scolded or lectured. So that's a common issue for withholding information. Suggestions for clinicians is to discuss what they would do with knowledge in advance if their patient stopped their med or did not follow the treatment plan, present it in terms of safety and avoiding confrontation. What you might want to do as a patient is, and if you've had struggles with your doctor in advance is bring that up in advance. Say, look, from time to time I have stopped my meds. If I tell you, will you like be pissed off at me? Or you could be more polite than that. And try to work that out in advance, and then you can decide whether that is a safe person to work with. And so the other aspect of this is for doctors is to think about why is the patient, what is the patient going through with model that has been used, and go over that. The research I have done in this model is in schizophrenia, but believe me, I have colleagues, Martha Sajatovic, that many of these things cut across diagnoses and I think are just as applicable to bipolar disorder as they are to schizophrenia. And this model is called the health belief model, which is now goes back to the 70s. And it's a psychological model which says that, well, a medication decision is some kind of end result of a patient thinking about the pros and cons of staying on a medicine. Now, that changes over time, but there are some really important aspects of this that to understand. First of all, it's not whether there are benefits to the treatment. It's whether the patient thinks there are benefits. So my grandmother had glaucoma, and she went blind because she didn't follow her eye drop recommendation, because she did not know how serious glaucoma was. So she didn't think she was benefiting. So it's perception of benefits, not actual benefits, that matters. Same thing with perceived costs. It's not whether, by the way, cost here is not dollar cost. It is, the cost of being on medication, a psychological cost or a side effect. And you weigh that, and if the benefits outweigh the costs, well, then you're going to take your meds. And if it's the other way, if the costs outweigh the benefits, then you stop. Now, all of these models they all have problems, but this is a very useful one in understanding a little bit beneath the surface why people do or don't take meds. And it's not always what you think it is. So remember, it's perceived benefits, it's perceived costs. The general rule with the health belief model is that perceived benefits almost always trumps perceived costs. Let me translate that into English. If you think you are sick and you need help, and meds will help, that's perceived benefits. And if you don't take meds, bad things will happen. That will be a stronger motivator to take meds than if the meds make you feel lousy or sick or upset. So you're willing to put up with a fair amount of side effects if you think you have to take it for benefit. If you don't think you're sick or need anything, you're not willing to put up with any side effects. But it's more than side effects. So why do people say that they're going to take medicine? And I'm going to give you a few pointers on this in terms of what happens with behavior. Well, sometimes people with bipolar disorder, they relapse. They go back on meds, and these meds can prevent or delay relapse. And that motivation is fear. You don't want something bad to happen. And that's a very powerful motivator. But women who've had childbirth more than once without anesthesia may remember or may do that because pain has no memory. Over time, the bad stuff of that relapse kind of fades from memory, whereas the hassle or the side effects stay. So there is a decay over time about the motivation for taking a medicine to prevent something bad from happening in the future. So that's just the nature of the beast. That is true for antibiotics, true for lithium, and true for medications that prevent heart attacks. preventing something in the future or preventing a relapse is a good motivator if something's bad happened to you recently, but kind of wears off over time. If, however, you're on a medicine and you feel like you get immediate benefit, like back pain and you take a anti-inflammatory, or you have headaches and you take a migraine medicine, that is a stronger motivator for ongoing adherence. Now, the thing with psychiatric disorders is those symptoms that help people does not have to be how doctors label symptoms: manic symptoms, depressed symptoms, psychotic symptoms. So an individual may see it, if they take medicine, they sleep better, they're relaxed, get along with other people, and that may be sufficient to stay. People who feel benefit from medicine tend to stay on medicine in the long run. Here's the one that doctors miss, and the big reason that people do take medicine is out of relationships. So doctors tend not to be as aware of that we do things. I take my meds because my wife would kill me if I did. No, that was a bad joke. But we are motivated for many reasons to take medicine in relationships. We want to be approved. We want to avoid conflict. We value a person's opinion, be that a family member. There may be, for clinicians, the white coat effect, deference to medical authority, desire to please, or perhaps there's a doctor or a clinician who really gets it and understands you, and you will stay on that. So that relationship aspect is a crucial aspect of adherence. So what does that tell us? Is that if relationships change, you change doctors, or you have a new person in your life, a boyfriend or a girlfriend, or that can often change whether someone's willing to take medicine or not. This again is something for clinicians. Now, life goals is another issue. That why do we do things? We want to achieve goals. This is maybe a little bit relevant. For instance, in schizophrenia, I've had many patients say that if they're on medicines, they're not marriageable, they'll never get a job, or they'll be frowned upon. So if you feel that medicines will help you achieve what you're living for, that's very important. And of course, some patients feel pressured or coerced. Now, I will show you some work that we've done with young people with recent diagnoses. And many young people, or teens or 20s, who get a diagnosis of schizophrenia or bipolar disorder do not say, aha, I agree, I have bipolar disorder, I agree, I have schizophrenia. And, and they don't buy into the concept. And one of the important things we found in this research is that many of the reasons that people take medicine does not require saying, I have bipolar disorder, I have schizophrenia, I have OCD. These are issues related to benefits or relationships or life goals that are independent of what the label is. And if someone objects to a label or a diagnosis, that can be a real barrier. So we'll get into that. So why do patients stop medication? Well, if you don't think the med works, you're not going to take it. And if you feel it's not effective, if you feel you're not sick and you disagree, or if you feel like you're depressed or suicidal and you're not sure whether that is a side effect or your illness, you may say, hey, it's a side effect. Now, here's the very important thing about this. When some of the medicines came out in schizophrenia, or also some of the mood stabilizers that are a little less burdensome in terms of side effects relative to the older meds, often doctors thought, hey, we're going to solve the adherence problem, less side effects. And what happened was the adherence problems, people stopping their medicine, is still about as common in bipolar disorder and is about as common in schizophrenia and all the major psychiatric disorders as it ever was. And that is probably explained by it is great to have meds with less in the way of side effects, but if you don't think you need it or the meds don't work, well, you're not going to take it no matter what. One point about stigma is, and this many families have a lot of frustration with family members who do not take meds and they feel they don't get it. You know, benefits are so obvious and yet this person doesn't stay on it. And there is a issue, I think, that is a very important thing for families to take home. And that is the crucial role of stigma in driving many people's decisions not to take medicine. And there are two kinds of stigma in the stigma literature. One is called felt stigma, meaning that the mental equation is, I grew up thinking mentally ill people are bad, lazy, stupid, or unlovable. So if I have that mental illness, it means I am not good, weak, unfit, or unlovable. If I take medication, that proves that I have a mental illness and I am not good, weak, or unlovable. Therefore, I won't take the medicine, and that will give me some chance that maybe I'm not mentally ill. Now, in those situations, if someone then takes medication, the last thing you want to do is tell that person in the cartoon on the right, hey, John, see, you're so much better on that medication. See, you have bipolar disorder. See, that is a sure invitation to stop medication. Because if the cost of being on medicine means acknowledging that I'm unfit or unlovable in that psychological equation, even if I benefit from medicine, that may be too painful. There's another kind of stigma, externalized stigma. Well, I may feel okay about myself if I have bipolar disorder, but I see that there are diseases which are discriminated against in the real world. And that includes, Ebola would probably be the biggest example, but people with mental illness, HIV, they're not respected or they're discriminated against. And I know I have a mental illness, but if I don't want anyone to know, because I don't want them to disrespect me or discriminate against me. So this is not a internal thing. This is more of an external world thing. And here's the point: is sometimes psych meds are visible. You take them with you when you date someone, or you have a side effect like a tremor, or a bloating, or a kind of glazed look that is a tip-off that the person is on some psychiatric medication. And that really has to be avoided for someone who's very sensitive to that. And then interfering with life goals, that's another reason. And we've covered this, opinions of others, friends, partners, and so on. So if you are caught between a rock and a hard spot, a doctor who says take medicine and a spouse who says don't take medicine, many people appropriately would want to get along with family more than their clinician. And then I've covered the lack of alliance. These slides, I think, or this talk is available, so it's a bit more complete as I'm going through these, and I think you'll get the sense. Now, the issue of taking recreational drugs or alcohol, often clinicians will say, hey, it's dangerous to take lithium and drink or get high. So then people do the natural thing, which is to stop their prescribed medicine in order to get high. If that's happening to you, if you hear that message from your clinician, your loved one here, you really need to clarify, if the fact of the matter is I'm still going to be using recreational drugs or alcohol, even if that's against advice, should I stay on medication anyway? Be very specific about it. Now, what about side effects? Side effects are often issues that are important, and I'm going to just show that doctors often get side effects wrong. Here's a Camel ad, and the fine print says, I'm a doctor, trust me, not one single case of throat irritation due to smoking Camels. And the fine print is, yes, these were the findings of noted throat specialists after they examined a lot of people. So, the credibility of physicians is they tend to not recognize or downplay side effects. Patients are always, in surveys, more distressed by side effects than the clinicians are. Clinicians are saying, look how much better the patient is, and the patient is more concerned about something that's causing distress. Now, sometimes stopping medication is the only way an individual can make the point that they don't like the side effect in a way that the clinician will take that seriously. So it's the distress from the side effect, not how severe it is, and that this is a very important area for doctor-patient communication, because even if the side effect stays or the response is limited, the feeling that the patient has that you can trust your doctor and your doctor will listen is much more important than getting into a power struggle and alienated from a clinician and then stopping medication. So ask your doctor if taking the pill to solve all your problems is right for you. So I'm going to end this talk about how, you don't want to say that the definition is all wrong. If we got, we can do better without at least coming up with an idea of a better way to address adherence. One thing I've already said is adherence is really better off if we discuss it in a dispassionate way it's about efficacy, it's not about obedience, and it's about information. So it's not something that we bury that in a and don't ask, don't tell. The other thing I think is important to think that most people with many bipolar disorder or serious mental illness get these things when they're teenagers or young adults. And we can view, that's a lot younger than many of us who have illnesses that happen to us in our 40s, 50s, or 60s. By the time I'm almost 60, by the time I'm 60, my friends have a condition, I have a condition. We're used to sort of health behavior and risk avoidance. Well, what about viewing adherence as a developmental trajectory, like many aspects of development? And way back in the 70s, there was a beautiful article about this, about adherence as a developmental process, that when young people get sick, they're forced to take meds by their parents or by their authority figures. They're pressured, and that's normal. And then eventually, if things go right, they figure it out with the alliance, with the clinician or the family, and eventually, to the right of this, figure it out themselves, and then they become genuinely motivated to stick with a regimen, to participate in the treatment plan. And that this can take years, and it's a development. So not to make it into a I win, you lose battle between the clinician. Is there any evidence for this? Well, if you go into the adolescent literature, now I'm not talking about mental health literature, I'm talking about pediatric literature, you will get articles that are somewhat radical relative to the standard way of adherence. And the data on this is that if you are a boy or a girl, a teenager, and you get a diagnosis of some chronic medical condition, asthma, juvenile diabetes, hemophilia, something kind of bad that happens to you when you're young, when it really shouldn't, and then you look at the risk behavior in these youngsters, you will get what I think are astounding, at least um, interesting findings, that girls and boys increase their risk behavior. So just to show you the first two columns, if you're a girl with a chronic medical condition, you don't wear seatbelts 25% of the time instead of 13% of the time. You're more likely to smoke. You're more likely to have temper outbursts, hit or break something when angry. So if you get a diagnosis of a chronic medical condition, you do other things that are unsafe more frequently than your peers. That is not the reaction that grown-ups have when you're older and you get these diagnoses. So there is evidence for a developmental period where if you're young and you get some diagnosis, medical or psychiatric, you will increase your risk behavior in general, more smoking, fighting, unsafe driving. Now, you have bipolar disorder where one of the symptoms is increased risk behavior. I don't think that's a great combination, but I think it also needs to be viewed, at least in part, as a normal developmental period. So we've had some federal funding for this. We have developed approaches, psychotherapy approaches that use this more of a developmental context that to try to help someone come to understanding of the pros and cons of medicine on their own. It is not a sales pitch to take medicine, but it's more interested in how to help patients understand what medications have in their lives. And it emphasizes health over illness and the alliance with the clinician over compliance. So we're taking this literature about the relationship and putting that to the forefront, and then discussing with the individual the role of medicines in either achieving or interfering with life goals. I can't say that this necessarily works. What I can say is the other way of telling individuals they need to take medicine over and over and over again when they don't doesn't work. So we need other ways. I can also say this seems safe in our research with young people with recent diagnosis. And the other part of this is that if someone wants to go off medicine, at some point we don't necessarily agree, but we will help them go off. We view it as a part of the condition, and we want to prevent hardening of the individual's attitude against medicine or psychiatric treatment. So it's not that we're against medicine or we recommend people going off, but we'd rather hear about it and rather help someone than have them go underground and not and not partner with us. This is we've developed a CBT intervention for young people with recent diagnosis of psychosis, and we have done this study. So this forms the basis of the study, some of the issues that we've talked about in the last hour. So in conclusion, adherence is not an outcome. It's a mediator of outcome. The definition of adherence, in my opinion, is fatally flawed. We've been at this for 30 or 40 years, and treatments are better, but the problem stays with us. And I think it has, one has to change it into efficacy at the very least. Is the person behaving or following recommendations in a way that is towards a goal, an effectiveness goal that is required before you talk about anyone being not adherent. And that there are a lot of other fallout of the way adherence is viewed now, which is poor information and increased safety problems, and that it can also harm rather than help the therapeutic alliance. So I think, Debbie, I'm going to leave this to you to handle the questions. I want to thank you so far for providing a platform for these ideas, and I'd be very interested in hearing your questions or thoughts on this.
Wonderful. Thank you for your insight and information. as Dr. Weiden expressed, he is now open for questions. And it looks like if you're coming in, let's see. I just want to remind you that this talk is being recorded and will be archived on our website for future viewing, sharing. And also, if you'd like to donate to the International Bipolar Foundation to help further these webinars and our San Diego quarterly lectures, you can go to our homepage at ibpf.org and click on the donate button. Okay, looks like we have a question regarding medication or adherence or acceptance of medication. Dr. Weiden, does this increase with age? Is the acceptance typically increased with age, as young adults typically are not supportive of medication, or this person, sibling?
Absolutely. There's, as we get older in life, we learn. So, yes. So that first of all, there's a learning effect. If you stop lithium once and you get sick, how do you, other people are telling you there's a relationship, but there may be other reasons. And if that happens a few times, there is more likely to be a learning effect. And that's true in all the adherence literature, is that learning is important. Now, the caveat here is that with psych med, sometimes there's a long lag between stopping and having problems. There's also the stigma issue. So it's hard to show a one-to-one correlation. But yes, learning is important, and as we all know, people need to learn in their own ways, and we can help them with that. One thing I do in my practice is that, again, I encourage people to tell me the truth about adherence. My responsibility then is not to get pissy or angry about it, but set up a plan. But also part of that plan is to view it as an experiment, so that if the person does fine going off the medicine, I'm very happy for them. If there are problems down the road, we will restabilize and then have a review once that person's stable. Now, there are times where it'd be so risky, or, again, this is not saying I would agree with the person, but I certainly rather know about it so we can do that learning. And I think that is true for many conditions.
Great, thank you. Is there a typical specific age where adherence is more acceptable, or just vary by person?
It varies. Now there are also some there are also some observational bias issues. What I mean is that if you're a young person and you accept your diagnosis in medicine immediately, you or the family won't be talking about that as a problem. You've moved on. And likewise, if people with adherence problems who never see the doctors aren't going to see. So there's some observational aspects of this, but generally speaking, I would say that after the earlier mid-20s, often things change. But these things are often measured by years, not by months, which can be very frustrating for loved ones who see someone struggling with this. I think to set if you're living with someone, there are limits, there are things you want to do, but understanding that this is a normal problem, not just for people with mental illness, but for people with diabetes or asthma, I think can sometimes help reduce some of the frustration.
Great, thank you. Is there, or do you have specific thoughts about creating relationships with your family or caregivers, creating that relationship with the patient and doctors, et cetera? Do you have specific guidelines or questions to ask or ways to present to a clinician if you don't feel that they're creating the atmosphere, such as you speak about relationships?
Yeah, what I would do is, sometimes if you hear something that kind of is, if you're going to tell the clinician something they don't want to hear, you can ask them in advance. Look, I'm worried about bringing this up because I'm worried that I don't want you to think of me as a bad patient, or I'm worried that you're not going to work with me on this. So if you sort of prepare it in advance so that the clinician can and then you tell them that can help. I think if a clinician really has trouble with accepting that, um, um, you may want to see if there are other clinicians who are a little bit more flexible with this. Again, I'm not saying that you want to, as a clinician, I still have to give my recommendations, and I may not agree, and I have to communicate that clearly. But how I do that, if I do that in a respectful way. The other thing I think families and clinicians should discuss is, you know, what will you do if you have the information that someone living in your house or someone you are close with isn't following the regimen, and to discuss that in advance. How are you going to handle that information? It can be tricky, but I think advanced discussion can be helpful.
Wonderful, that was great information. It looks like that's it for the questions today. So I'm going to wrap it up and thank you once again, Dr. Weiden. If there's any question that comes up in your head at a later time, you can email that to me at dbrown.
Yeah. Well, actually, I would, one final thought, in terms of specific issues for bipolar and adherence. Kate Jameson has written a chapter on that in the textbook by Jameson, by Goodwin and Jameson, which will go into a lot more detail on some of the specifics in terms of reasons with bipolar.
Excellent. Thank you for that add-on. As I was saying, if you do have a question down the road, just email it to me at dbrown@ibpf.org, and I'd be happy to forward that question to Dr. Weiden and try to get that answered for you. So again, thank you for joining us, everyone, and thank you, Dr. Weiden, for your information and insight, and everyone have a wonderful day.
Thank you.